We are going to study about an ENT topic called peritonsillar abscess, also known as Quinsy. Before understanding the etiology, let us know the definition of peritonsillar abscess or Quinsy. It is a collection of pus in the peritonsillar space which lies between the capsule of tonsil and superior constrictor muscle. You can see here the capsule of the tonsil. In the right side you can see the tonsil, the capsule of the tonsil and the superior constrictor muscle. I'll show you in the next slide. Here you can see here the peritonsillar abscess. This is a capsule, so this is a tonsil, the capsule of the tonsil and the superior pterygoid muscle constrictor, superior pterygoid constrictor muscle. In between them the space is known as peritonsillar space. What is the cause for the collection of pus in this peritonsillar space? The etiology would be, it is usually following the acute tonsillitis. So a person suffers from acute tonsillitis first, and then following the acute tonsillitis, this quinsy can develop. Though it may arise without the previous history of the sore throats. It can also arise without the previous history of sore throat. It is not necessary that a person should have sore throats then land up in quinsy. It is not necessary. If a person is having acute tonsillitis, following the acute tonsillitis, a person can develop quinsy. Second thing, what they are saying, first one of the tonsillar crypts, usually the crypta magna, gets infected and sealed off. So here you can see the tonsil, it is containing crypts. These crypts, one of the name of the crypt is crypta magna. Whenever one of the crypts get infected, it is going to seal off. Once it is infected, the infection is sealing off in the tonsil. After it gets sealed off, it will form an intratonsillar abscess. Since it is sealed and it is present within, it is known as intratonsillar abscess. Then after filling up, what happens? It will burst through the tonsillar capsule to set up peritonsillitis and then an abscess. So you can see here in the picture what's happening in this. One of the crypta magna will get infected. After getting infected, what's happening? It will get sealed off. Then after filling up the pus, it is going to burst the capsule, then enter the peritonsillar space, causing peritonsillitis, that is inflammation of the peritonsillar space, and then resulting in an abscess formation, that is nothing but quinsy. The culture of pus from the abscess may reveal the pure growth of Streptococcus pyogenes, Staphylococcus aureus, or anaerobic organisms. So guys, you can see both aerobic and anaerobic are playing a function in formation of quinsy. When you do the culture of this pus, then you can find these organisms, that is both aerobic and anaerobic, that is Streptococcus pyogenes and S. aureus, Staphylococcus also. Both Strepto and Staphylo are involved, along with them some of the anaerobic organisms as well. More often the growth is mixed with both aerobic and anaerobic organisms. Hope this is clear. What is the etiology? How is it taking place? Following the acute tonsillitis. Then crypta magna will be infected. It gets sealed off. It will form an intratonsillar abscess. Then this abscess is going to burst open, resulting in peritonsillitis and then quinsy. Then when you do a culture of the pus, you find the aerobic and anaerobic organisms, that is Streptococcus pyogenes, Staphylococcus aureus, as well as the anaerobic organisms. Both mixed organisms are found. This is about the causation. Now let us see here the clinical features. The peritonsillar abscess mostly affects the adults and rarely the children, though the acute tonsillitis is more common in children. You see, quinsy is formed in adults, whereas the acute tonsillitis is more common in children. Usually it is unilateral, so it is one-sided, but occasionally bilateral abscesses are also recorded. So you guys, you can see here the peritonsillar abscess, it is affecting the adults. Acute tonsillitis is found in children. Usually it is unilateral, but then bilateral can also be found. The clinical features, you see, it has been divided into two types. One is general clinical features. The second one will be the local clinical features. Starting with the general clinical features, they are due to septicemia and they resemble any acute infection. that is resulting from an acute infection. What all do we what all do we get infected with? We get fever, chills and rigor, general malaise, body ache and headache. Nausea and constipation will also be there. So following any acute infection, the person will land up with fever, that is up to 104 degrees Celsius. In the same way, from the peritonsillar abscess quinsy, it is an infection. So what's happening here, resembling any other acute infection, the person will suffer with fever which is up to 104 degrees Celsius, chills and rigor, the general malaise is found, and the body aches, headache, nausea and constipation. These general symptoms will be found. Okay. Then let us look into the local features. Locally, near the peritonsillar space and the tonsils, locally what's happening? There is a severe pain in the throat which is usually unilateral. So we saw that peritonsillar abscess usually is unilateral. So the throat pain is also going to be unilateral. Odynophagia. Guys, odynophagia is nothing but the difficulty in swallowing, the painful swallowing. It is so marked that the patient cannot even swallow his own saliva, which is going to dribble from the angle of his mouth. So the severe pain in the throat is going to be there. And then second thing, odynophagia. Odynophagia, the swallowing is so painful that the person is not able to swallow his own saliva, which is going to dribble from the angle of his mouth. The patient is usually dehydrated. You see, he is not able to swallow saliva. So there is no question of consuming solids. So the person is not even taking solids as well as liquids. So liquids are also very painful. So the patient is dehydrated here. Muffled and thick speech, often called hot potato voice. So hot potato voice is a feature of peritonsillar abscess or quinsy. The person is going to have a muffled and a thick speech. Foul breath due to sepsis in the oral cavity and a poor hygiene. So the person cannot brush properly, he is not able to take his oral hygiene, take care of his oral hygiene. So the foul breath is also found in the people. Ipsilateral ear ache. So the similar, if the right side is the peritonsillar abscess found, then the same ear, the right ear only, the person is going to have the pain. So ipsilateral ear ache. If the left is affected, left side of the throat there is a peritonsillar abscess, so left ear is going to ache. So there is ipsilateral ear ache. This is referred pain via cranial nerve 9, which supplies both the tonsils and the ear. You see the glossopharyngeal nerve, which is supplying both the tonsils as well as the ear, is going to be affected here. Since this is the same glossopharyngeal nerve is going to supply the ear as well as the tonsil, it is going to cause a referred pain. From the tonsil, the pain is going to be referred to the ear. So there is ipsilateral ear ache. Then the last thing you see, trismus, it is due to the spasm of the pterygoid muscles which are in close proximity. Guys, you see here, trismus is nothing but lockjaw. There is spasm of the pterygoid muscles which is also in close proximity with the superior constrictor muscle. We saw there in the previous slide the superior constrictor muscle. In close proximity there was pterygoid muscle. Because of this close proximity, there is spasm of the pterygoid muscles resulting in the trismus. You can look in the picture here, the lockjaw trismus. Okay, these are the local features. Let's summarize again. There was pain in the throat, which is unilateral, odynophagia, difficult swallowing, saliva they cannot swallow, so it dribbles from the mouth. Patient is dehydrated. Third thing we saw about the hot potato voice. Fourth, foul breath because of the poor hygiene as well as the sepsis of oral cavity. Fifth was the ipsilateral ear ache. It is because of the craniopharyngeal nerve, that is 9th craniopharyngeal nerve, which is supplying both the tonsil and ear. Trismus will be there. Why is the trismus here? Guys, why do the person have lockjaw? It is because of the spasm of the pterygoid muscle, which is in close proximity with the superior constrictor muscle. Okay. Next thing, let us look into the lab investigations. The complete CBC, blood count and the electrolyte should be done. Heterophile antibody test. It is done to rule out the suspicions of infectious mononucleosis. So you need to rule out if it is infectious mononucleosis. So you do the antibody test. Pus culture sensitivity from needle aspirate of the abscess. So we saw that we do the culture and we find out if the streptococcus, the staphylococcus, which is the organism causing. So the pus culture sensitivity, it is done from the needle aspirate of the abscess. Then C-reactive protein blood culture for the patients presenting with the features of sepsis. So if a patient is presenting the features of sepsis, you need to do C-reactive protein test. Okay, CBC, heterophile antibody test, pus culture sensitivity test, and C-reactive protein test. Radiological investigations, the X-ray of the soft tissues of the neck, and also the contrast enhanced CT is required in a very young patient. So you see, X-ray and CT scan is done in the radiological investigation. For diagnosis, the confirmatory step is guarded needle aspiration of the swelling. So we do the needle aspiration, the culture of the pus, find out the organisms, and then conclude its quinsy. The presence of the pus confirms the diagnosis of the quinsy. A proper incision is needed at the most prominent bulge. Guys, you can see here the needle guarded very carefully. They are going to do the incision at the most prominent bulge, which should be opened with the forceps to drain out the pus. So you can see here, when they are doing an incision, it has to be opened with the forceps so that the pus can be drained out. This is about the diagnosis. First thing, we do the needle aspiration. If there is pus, it will confirm it is quinsy. And while making an incision, it should be done at the prominent bulge and it has to be opened with the forceps to drain out the pus. Then let us look into the treatment of quinsy. Surgical incision and drainage, like how we discussed here, the surgical incision and drainage should be done. Analgesics and antipyretics are given to relieve the pain and fever. So you saw the general symptoms are found, so you give them analgesics to relieve the pain and antipyretics for fever. Quinsy tonsillectomy. If all these fails, even after giving analgesics and antipyretics, the patient is not improving and the quinsy is going on spreading even more further, then you have to go for quinsy tonsillectomy. That is removal of the peritonsillar abscess. Indications for quinsy tonsillectomy. When do you conclude that the person have to go for tonsillectomy? The possibility of a subclinical contralateral peritonsillar abscess being present. Whenever there is a contralateral peritonsillar abscess, there is a possibility that even the contralateral peritonsillar abscess can also be formed. Then you can go for quinsy tonsillectomy. Second thing, the patient is not responding to the intravenous antibiotic treatment. So guys, you can see here the person is in such a state that he is not able to take his saliva. So it's highly impossible that he is going to take the antibiotics from the mouth. So intravenous antibiotic treatment should be given. And the incision and drainage of the peritonsillar abscess, when the person, in spite of giving a proper incision and draining their peritonsillar abscess, yet there is no improvement, there is contralateral spread of the abscess, then you have to go for quinsy tonsillectomy. Okay, hope it is clear. Then the complications will be parapharyngeal abscess, retropharyngeal abscess, laryngeal edema leading to airway compromise. You can see here there is parapharyngeal abscess, retropharyngeal abscess and laryngeal edema. These are the complications. Now what is the definition of a peritonsillar abscess? You guys have to put it down in the comment section. The options for you guys is a tumor in the mouth that is filled with blood, a blister on the tongue that is filled with debris, a mass by the tonsils that is filled by pus, a mass in the throat that is filled with blood. So whichever is the right option, you have to put it down in the comment section. The last question for you guys, name 3 symptoms of a peritonsillar abscess. Is it fever, difficulty swallowing and ear pain on the side of abscess is the first option. Option B is coughing, bad breath and gland tenderness of the throat and jaw. Third is